Hi, everyone. We're going to take a few moments to just get everyone into the Zoom room. We had a lot of signups for tonight's event, but we will get started in just a few moments. Thank you so much for attending tonight. We're looking forward to this important discussion. It will be just another minute or two. While we're waiting just for a few moments, just tell us who you are. Are you an alum? Are you a current student? Are you a prospective student? Are you faculty staff? Let us know in chat. We'd love to know who our audience is today. While we wait for everyone to join us, we'll get started in just another moment. Oh, great. A lot of incoming students. We're so excited to have you. Great. So I'll continue to, we'll get people let into the room, but welcome everyone to Women's Health Unspoken and New Support Systems, hosted by the USC Suzanne Dvorak-Peck School of Social Work, the Office of Admissions, Academic Operation, and Alumni and Career Services. My name is Amanda Decker, and I am the Senior Development Officer for Constituent Relations and Advancement Operations here at the school. This evening, I am joined by an amazing panel of women from the USC Suzanne Dvorak-Peck School of Social Work, and we will hear from our dean, faculty, and an alumna about women's health concerns in our current climate. If you have any technical difficulties, please indicate so in the chat, and I'll be sure to help out with your concerns or any difficulties. If you have any questions for our panelists as the discussion happens, please be sure to use the Q&A feature, and at the end, we'll have time for 1 or 2 questions from those that you have asked. Before we have Dr. Cederbaum, our moderator, introduce our panel, we have a special announcement from my colleague, Assistant Director of Admissions, Ron Rubalcaba. Ron?
Thank you, Amanda. Good afternoon, everyone. As Amanda mentioned, my name is Ron Rubalcaba. I'm the Assistant Director of Admissions and Recruitment for the USC Suzanne Dvorak-Peck School of Social Work, particularly our campus-based program. I wanted to talk briefly about a few of our programs that we do offer. I do see a number of incoming students, so this will be of some interest to you as well. So the first program I'd like to discuss briefly is our Social Work and Juvenile Justice minor. Now, this minor is designed for USC students who want to increase their knowledge of the juvenile justice system, the various service environments working with diverse youth populations. So this minor, it's fit for those in the behavioral and the social sciences, and it may interest students that are interested in developing a broad knowledge of issues in the field of juvenile justice. Now, this minor is of particular interest to students wishing to pursue graduate studies in social work, as well as law, sociology, psychology, public health, or education. Some of the required courses are institutional inequality in American political and social policy. Another one is adolescent gang intervention, among 2 other courses as well. Now, in addition to that, the USC Suzanne Dvorak-Peck School of Social Work is proud to present a progressive MSW program. Now, again, this is designed for USC undergraduate students, and this program is going to allow students to earn both their undergraduate and a master's of social work in as few as 5 years. So undergraduate students who have completed or are in the process of completing this minor, they're highly encouraged to apply. Applicants who have completed the juvenile justice minor will complete less than the 60 units normally required for our traditional MSW program. Now, in addition, we also welcome applications from other USC undergraduate students who, again, will complete less than the required 60 units for the MSW program. Now, we do offer the MSW, the Master's in Social Work, in a number of formats to meet the various needs of our students. We do offer, for those who have a bachelor's degree in social work, we offer the 37-unit, one-year advanced standing MSW program. Now, that does start in summer of 21. If you're interested in that one, you need to speak to me right away. For fall applicants, we do have our traditional 60-unit MSW program. I recognize several of the names that are in our fall program. We offer that in a 2-year option. We offer that in a 3-year option. Courses are in the fall and spring only. You will complete 1,000 hours of internship at 2 community-based internships. In addition to the fall traditional MSW program, we also have our working professional MSW program. It's a 7 consecutive semester taking classes in the summer as well. It's a 28-month program offering guaranteed evening courses with a very consistent schedule, one that you can plan the next 28 months around. It is a hybrid program. So 1,000 hours of internship is going to include both our virtual training as well as 1 community-based internship. Now, in addition to our MSW program, we do offer a number of dual degrees. As I mentioned, I saw a number of incoming students on the chat box, and so this may be of particular interest to you. We offer a dual degree with the School of Law, Business, Gerontology, Public Health, Public Planning, Public Administration, and Jewish Nonprofit Management. Now, with the exception of the law and the business, each of these other programs, you could apply this first semester. So the incoming students, if you haven't applied for one of these dual degrees and one does interest you, you can definitely apply this fall. And if you have additional questions, I'll provide my contact information in the chat box. So if you're ready to learn more about the social work profession and how you can make a difference in your community, if you want to inspire, if you want to empower and advocate for marginalized populations, then reach out to us at apply.msw@usc.edu, or you can visit the website for more information. I will put my email address and a few links in the chat box. So if you have any questions, feel free to reach back out. Now, I would like to introduce Dr. Julie Cederbaum, Associate Professor at the USC Suzanne Dvorak-Peck School of Social Work, and tonight's moderator. Thank you all. Fight on.
Thank you so much, Ron, for that great intro and grounding in our school and all of the amazing programs and opportunities that exist at the Suzanne Dvorak-Peck School of Social Work. My name is Julie Cederbaum, and I am pleased and grateful to be able to have the opportunity to moderate this panel today. I want to thank you all for taking the time to join us and discuss women's health in 2021. I'm really pleased to be discussing this critical topic during Women's History Month, while we also celebrate our profession of social work with social work, it also being Social Work Month. And while the health of all people is specifically, is critical, and work to increase health equity for all is critical, we have chosen to discuss women's health specifically for a number of reasons. Among US women and globally, US women's health ranks lowest among high-income countries. We have the highest rates of maternal mortality among high-income countries, as well as some of the highest rates of breast cancer. Cost of healthcare continues to be a critical issue in the United States, with 25% of US women reporting spending $2,000 or more a year on either themselves or their families related to health and wellness, and 1/3 reporting skipping medical care because of the cost of healthcare in the US. And so I am incredibly pleased to have a fantastic panel that I actually am going to have introduce themselves, because I believe that we all do that better than when other people talk about us. Tonight we have 3 incredible women, Dean Gehlert, Dr. Parker Dominguez, and Dr. Paul. So if each of you might be willing to introduce yourself by stating your name, your connection to the USC Suzanne Dworak-Peck School of Social Work, and speaking briefly about your current work as relates to women's health, I would love that to be the way we get started tonight.
Hello, good evening. Do you want me to go first? Dr. Cederbaum?
Absolutely, thank you.
Sure. So I'm Tyan Parker Dominguez. I'm a clinical professor in the School of Social Work, and I've been here nearly 20 years now. And I'm also the incoming new chair of our MSW program. So I'm really excited to see how many prospective students are on this, this webinar and interested in learning more about our school, our MSW program, and women's health. So my interest in this topic comes from having a background in health, both in my MSW. I was a health concentration MSW student, and I also earned a dual degree in public health, focusing on maternal and child health. And that's what my professional experience has been focused on, particularly on understanding persistent racial disparities in adverse birth outcomes, low birth weight, preterm delivery, and infant mortality, maternal morbidity, especially as it relates to African-American women who are disproportionately affected by those adverse health outcomes. So I am very happy to be here this evening.
Thank you so much. Dr. Paul, would you also be willing to introduce yourself?
Definitely. Thank you so much for having me tonight. So I am a USC alumna from last year. I'm cohort 6 for the DSW program. And one of the things that I do, I am an owner of Social Work Diva, a provider of online services, mental health services for women, particularly centering Black women. And also, I consider myself to be on the macro, I'm a clinical social worker on the intersections of macro work. So I do a lot of policy consulting for politicians in regards to mental health agendas and shaping and shifting that, centering Black women, because that's a lot of my work and research, but also very interested in Black maternal health also, mainly because like in October of last year, a little bit after graduation, I was somewhat affected and intubated as a result of my birth experience. So 2 days later after discharge. So it's something that I've always been very interested in, and I'm just happy to be here.
Thank you so much. I always, every time Dr. Parker Dominguez introduces herself, I feel like we had this like very mirrored path of a health focus and a dual degree in public health. So I appreciate the public health social work perspective that both of you are going to bring. And our dean will be joining us in the coming minutes. She is running between meetings. So I am going to take the opportunity to introduce her as well as we move forward. Dean Gehlert is an expert in health disparities and the disparities in treatment, particularly related to women's health and mental health, particularly how people adapt to serious illness and injury. And she has done extensive work in the areas of oncology, as well as violence and unsafe housing for African-American women, particularly those diagnosed with cancer. She's also the co-author of one of our premier books on health social work in the field, which is the Handbook of Health Social Work, which is now in its 3rd edition. So we are excited to have her join us, and I think she will be popping in as we kind of get rolling in our conversation. So that the audience knows, I had sent our panelists a few questions ahead of time so that so we could get grounded in the topic and have a sense of kind of where the conversation at least will start. We look forward to your questions in the chat to further spark our dialogue and discussion. I would love to start by having each of you kind of just talk about what you see as the greatest prevention and intervention needs for women.
I guess I could start unless LaShawn, you'd like to start?
Yeah, you can go. I was just unmuting myself.
So there's a lot. But I'm thinking, especially this time of COVID, this now 1 year time that we have all been affected by this pandemic has really made very evident what some of the deepest needs are in our society and who are some of the most adversely affected populations in our society. I think it's really laid bare just how deeply inequities go in our society and just how much work we have left to do in terms of promoting equity, promoting social justice, making sure that we take care of those who are most in need and marginalized in our society, straight to the core of our calling as professionals, social workers, and the mission of our profession. I think it's just been made starkly evident through COVID. So first of all, I'd say in terms of prevention, we have to, I think of that in terms of preventing illness, right? Preventing adverse health outcomes, mental health outcomes. And so one thing I think that we have to do a better job of, and which was manifested throughout COVID in a variety of different ways, is making sure that people have what they need just to live, just to survive, just to subsist. We saw so many people who experienced housing insecurity, food insecurity, healthcare insecurity, lack of access, right? So I think just having the basic needs in place to just subsist, to just live your life, to feed your family, right? To house your family, those basic things in place. I think that's definitely one of the biggest issues. We saw women lose their jobs at a disproportionate rate related to men during COVID. We also saw women having many more issues or demands placed upon them in terms of if they were still working, also a lot of childcare and caregiving, family support related issues. So I don't want to get too far ahead of us, but so that's sort of the prevention end. On the intervention end, I'd say access to care. Huge issue that we've been dealing with in our country now for not just COVID, but the inequities that we have, not only in terms of access to care and healthcare coverage, insurance coverage, and all sort of the debates that we've had around universal healthcare, but also in terms of quality of care. When we think about disparities, health disparities, which is my area of focus, that's one of the biggest concerns is sort of the multi-tiered system that we have and how much is driven by economics. And if you don't have a lot of money, that affects your access and that affects the quality of care. So those would be my two.
I think she touched on like everything, right? So for me, I always talk about my 2 A's also, right? So access and awareness and how valuable having both of them are. And when I think about it, like social determinants of health and all of the other isms that exist that all women intersect in various spaces, I think those things are very important. But when I really think about even prevention and intervention challenges, it really boils down to money, right? I think that the gender wage gap plays a significant role not only the job losses, but now we're fighting for like the $15 minimum wage. And we realize like a significant amount of women are the ones affected by those low wage jobs. And I think that we can't necessarily get women to recognize, to kind of take off those superwoman capes and other things that, and all these roles that society has placed on them, and get the care that they need if there isn't the money involved in order to access those things, right? So making awareness like a big part of our part is important, but the other part is making sure that access is fair, equitable, and especially with COVID, what we recognize is like the big digital divide, right? So a lot of things were pushed telehealth wise, but if you couldn't necessarily afford or had access to the internet, and those who were previously in rural areas, right? We're in city areas, so we sometimes forget like the rural areas that aren't able to access the quality care that we are in the city, and how those things play a significant role.
No, I think you both have touched on really important topics. Dean Gehlert, thank you for joining us. We know that you are ping-ponging today between events, so thank you. We were just opening up. I took the liberty of introducing you. I hope that was all right.
I'm sure it was accurate.
And oh, good. I did my best. And so we were just opening up, talking about kind of what you see as the greatest prevention and intervention needs.
So I'm sort of a historian of health social work, so I always sort of step back a little bit. And I think that social work focused on intervention and treatment for a long time, over prevention for many years. And I'm old enough to have remembered sort of the battle. We began working in healthcare and hospitals and gradually moved to the community, and we're moving further and further out, and it's absolutely great, into the different communities. So we went from hospital social work at the beginning to, then we called it medical social work, and now we're calling it health social work, which kind of shows the breadth of what we're doing. And it's the two very important pillars are moving to the community and moving from treatment to prevention, which means that we've got to establish ourselves with other professions and disciplines to carve out our space. And it kind of brings together the rest of social work with health social work, which makes it really important. So I work in breast cancer and look at breast cancer disparities. Black women are 40% more likely to die from breast cancer, even though they're no more likely to develop it. And we've been working for years to figure that out. So it's the most common cancer in women, and it's the second cause of death of women, cancer death after lung cancer. And 1 in 8 women will develop breast cancer in their lifetimes. And now that that survivorship is longer, women are going to live with breast cancer for a long time in their lives, and brown and black women will develop it at a younger age. So I think that's an important role for social work, and we have to be there. So, and my pet peeve is when we say we're going to educate women, or we make the entire onus for staying well on them, on health behaviors, instead of looking more systemically. And I think that COVID has pointed out, Lisa Newman wrote this wonderful article about the parallels between cancer and COVID, and that we're doing a lousy job at health messaging. You talked about rural women. I actually grew up rural, and it's an incredible problem when you're cut off that much from the mainstream news. So social workers should have a big role in health communication, I think, and we haven't been there. And it's interesting to me because health social work was developed to be translators. So in 1905 in Massachusetts General Hospital, Richard Cabot, who was a doctor, said, social workers should be the translators. They don't have a role that really causes their allegiance to be any one place. So they should be explaining to physicians what the life experiences are of women and their families, especially. When doctors used to say green vegetables, and these were women who couldn't have afforded it at all. And also to explain, to translate medical information to people at a level that they can understand it and that fits with their values and their health literacy. So I think it's a really important role for social workers in COVID. And let's see, what else did I write? I think including communities and planning will really help health communication. We also haven't done that enough. When I read a personal statement to get admitted and it says, I want to educate people, I think, oh my goodness, you need to be educated yourself. So let's see. So I led a breast cancer disparities center in Chicago. And what I learned was, as a researcher and academic, you need to work with community members to change policy, to advocate. So I presented one day to a big group of women with breast cancer and organizations and other universities. And it turned out that women almost immediately went to the Illinois legislature and started advocating. And we were able, from the research, to pass 3 bills. One that eliminated co-pays from mammograms for women, and that was a big help. And also one that allowed just a little bit of Valium or something like that for women who were petrified of mammograms. And the interesting thing there was, they didn't even ask for the medication, but it improved the rate of mammography. So that's kind of my thoughts for the day on that question.
No, I appreciate that a lot. And what I heard from all 3 of you is really the centering of social work as a profession that's promotive, preventive, and does intervention work. And I think that that's really critical for the audience. I think that who's listening to us now is recognizing that social work doesn't just pop up professionally when the problem occurs, but that we have a great role in working to prevent and promote health and well-being. And I heard from multiple kind of this transdisciplinary approach and interprofessional practice, right? Working across different disciplines together to meet needs, the inclusion of all voices, right? Our communities are the experts in their own health and well-being. And when their voices aren't included as part of the discussion, we lose valuable information to meet individual needs. And then last, I think just kind of before I move on to the next question is really this, all 3 of you said just that basic needs are health needs, right? That when we meet basic needs, we are changing the health and well-being of our communities. And so, I think sometimes we get caught up in the fancier, bigger things, but sometimes it's really just reducing poverty, reducing hunger, stabilizing housing. These are the precursors to stress events that then lead to health events, right? So I really appreciate the framing by all 3 of you related to those topics. What policy changes? We have a new administration. We're seeing a lot of change. We also are seeing a lot of state level policies that particularly seem to be targeting the reproductive health of women. So I'm wondering what policy challenges you see to meeting some of the needs that you all have raised or each have raised. Maybe Dr. Paul, you can start.
Like, I am very familiar with the Congressional Black Caucus for Women and Girls just recently came out with a whole policy agenda list. And one of the big things on there was the Black maternal health issue, in addition to the breast cancer issue that Dean Gehlert mentioned, right? So it's about maybe potentially getting different changes in the American Medical Association to look at different disparities and to also then make recommendations on those disparities. So there, particularly for breast cancer, one of the things that I feel that is necessary is earlier screening, right? So Black women are dying because they're being diagnosed, and by the time they recognize it when they're 40, it's too late, right? So I think like policy change within the American Medical Association is necessary, but on the broader scale in regards to the Biden Association is to making sure that Congress allocates funding for this research that does center that centers women in general, and also have women researchers leading it, right? People tend to be comfortable with researchers who are like them. And I think those things are very important within that space.
Can I add on to that a little bit?
Please.
Because I was going to say something that kind of is in the same vein, but a little bit different. So one thing that social work researchers have shown that's, I think, important for politicians, for legislators, is what happens when you expand Medicaid. When you make, and some of you in the audience, I hope you all know what Medicaid is, but it's public insurance. And some states in the United States, we allow each state to do it differently. And some states have expanded Medicaid to include more of these services and others haven't. But Heidi Allen at Columbia University School of Social Work and Christina Andrews at the University of South Carolina have done seminal research showing what happens. They've compared states that expanded Medicaid with those that didn't. And they found that in states that expanded Medicaid, women were diagnosed earlier and could start treatment earlier because breast cancer is just a rapid proliferation of negative cells, and it saved lives. And so I think being very careful about what policies we research and we push, and again, working with communities when we got this, like expand Medicaid, we can show you it saves lives, is incredibly important. And I agree with expanding reproductive health services, which under the Trump administration were cut back a bit, and letting women make decisions about their own bodies is important.
I agree. Dr. Parker Dominguez?
I would just add to that from the women's health perspective, and particularly around the issues we had mentioned earlier around maternal mortality, morbidity, that this is a major concern in the United States. We have, compared to other peer countries, a much higher rate of maternal mortality. Anyway, but there's huge disparities as well. And so what I had mentioned earlier is being sort of one of the key areas I see for prevention around making sure that people have the basics that they need just to survive, housing security, food security, access to care. Even in thinking about improving maternal outcomes, for example, the work that I've done around disparities in Black women's health and well-being, and doing a lot of talking with women and talking with community about what it is that they need, how it is that they understand the issues and the things that are involved and that relate, to the problem. What I see and what I hear is not anything related to the things that other folks might immediately bring to mind, such as prenatal care, or anything really sort of health related. A lot of it has to do with these other needs that can be major stressors during the course of a pregnancy, for example. Women who say that they don't know how they're going to pay the rent, or they don't know how they're going to feed their children, or they don't know how they're going to pay for diapers for their other kid, right? Or they're just sort of these living needs that really take up a lot of time and energy and create stressors for them during the course of a pregnancy, and just generally speaking, that can have an adverse impact on their physical well-being, their mental well-being, and stress has been related, for at least half a century of solid research around stress in pregnancy as being a major risk factor for an adverse outcome. So I think, again, those policies associated with earlier, Dr. Paul mentioned, for example, the federal minimum wage, there's also been pilots around a guaranteed basic income. That have demonstrated, one in Stockton, California, that launched in 2017, that have shown that when you give people a guaranteed money, and we're not talking $1 million. The Stockton trial, I think, was $500 a month that folks got, that they are responsible with that money. that they use it to pay the rent, that they use it to pay for food, that they use it to pay for things, you know, that their household needs. It was related to higher employment rates, full-time employment rates. It was related to better self-perceived health. There are a lot of positive outcomes that came from that. And I think that that's one area of advocacy for social workers in particular, around looking at these basic income supports, the federal minimum wage and other kinds of supports to help families, to help women and families and children to meet what their basic needs are.
I just want to add something really quickly because I'm a mental health girl and I don't know how I forgot that piece. Like there's one thing is in regards to expanding in the insurance, but current like issues and limitations of the insurance that exists now, right? I just recently received my new insurance and just randomly decided, let me call and find out what the behavioral health service, like what I can get from it. And they were like, you have 5, and we only do 5 diagnoses, right? And it was, and anxiety wasn't even one of them on the list that they would pay for, right? So I think that true mental health parity is also a big part, especially as we see how women are like negatively affected by all the stressors of life that everyone mentioned. But in addition to just, especially during COVID times, the additional stress and other things that have like increased mental illness within our country. I think mental health parity has a long way to go. And if we're really going to be talking about I think mental health is a big part of every aspect of health, right? Because one of the precursors of a lot of things is stress, right? No matter which diagnosis you're talking about on the physical end or the mental health end. And I think that's also another policy that we should be also looking at as social workers and as just social justice advocates, right? A big part of our role and what NASW calls us to do is to be this social justice warrior. And we're so pulled in various different roles within our job that sometimes we do the task and forget the important piece of advocating within the community, but also advocating with legislators and even tapping into that, right? I'm always a fan of saying we are all political social workers, regardless of if we identify that as such.
No, I really appreciate that framing and to be inclusive, like of the whole person, right? The mind-body connection, and that, you know, we can't just treat one part of ourselves without treating another. And so when our policies or practices only treat pieces, we're not actually providing a holistic solution, but rather, only treating or taking care of part of the problem, which isn't addressing any root cause. And I think all of you talk some about root causes, and this is going back to basic needs. And I want to kind of, Dr. Parker Dominguez, when you started the conference, you said early on something about childcare and just women's health and kind of some of the inequities that COVID has brought up related to caregiving. And I do think that one of the challenges, I was part of a national survey this summer of social work practice during the COVID-19 pandemic, and caregiver stress was a huge, particularly for women of color, came out very, very significantly as a challenge. And the other part or another kind of thing that kind of came out of that survey was really invisibility of our profession, right? Not being seen by our workplaces as essential or frontline, and not having access to PPE or not being part of policies for hazard pay, not those in private practice not having the ability to bill telehealth in the same way. And these are all policy changes. So we've talked some, or all of you talked some about federal policy, but I wanted to also say that kind of organizational and some of our more local policy, I think is also pretty critical to tackle. So kind of thinking about organizational, local, state, and federal, just to kind of build on everything that you've said.
In terms of local, getting back to kind of putting the whole onus on the woman to change behavior, get mammograms, blaming her if she doesn't. I think policies at the local level to make safe neighborhoods are important. We found an association between what we call hypervigilance, having to be worried at night that somebody's going to break into your place and never sleeping all the way, and the more aggressive kind of breast cancer in Black women. So another pet peeve is saying you should exercise more, and then when you look at neighborhoods, they're not safe. So really pushing local authorities to clean up parks, to make neighborhoods more safer and to try to get produce into areas where it doesn't exist. We blame people when they don't do these things, but we make it almost impossible for them to do it.
It's the classic sort of what we'd call a medical model versus an ecological model, sort of understanding for social workers, person and environment, right? That behavior doesn't happen in a vacuum. And when we tell people specifically around health behaviors, because this is a big issue in maternal and infant health as well, right? The blame or the onus being on the woman for a healthy pregnancy or not. And we forget that people exist within contexts, and they may fully understand what are health promoting behaviors, and they may fully want to engage in those, but they may be fully constrained or constrained in some way in being able to do that, such as eating a healthy diet, getting moderate exercise, all for the reasons that you mentioned, Dean Gehlert. And I think as social workers, as translators, as you mentioned earlier as well, helping our healthcare providers really understand and appreciate that context within which their patients.
And demonstrating it for them. That's where research comes in. I mean, I'm on a panel in California that's modeling breast cancer risk, right? So when you put in the environmental toxins and you put in the genetics, the model was really easy. When you started putting all the social variables in, it fell apart because it's so complicated. So we can't just talk to one another. I think we need to work to convince other disciplines and other researchers the importance of the social variables. It's not easy. So we all have to be advocates, practitioners, researchers, and that keeps life interesting.
I think something even as interesting in regards to like policy, Dean Gehlert mentioned like sleep deprivation, right? So especially with noise pollution in the city, we're constantly like, so when I'm in New York, so when we call 311, no one ever really comes and shuts down the noise that exists that often keep people up and often like increases like cortisol and a whole bunch of other things that affect weight, right? So while we are able to access so many different things within New York City, a lot of those things have been lost as a result of COVID, right? In regards to funding. So while we had like this comprehensive Thrive NYC, they're like, well, we're not doing mental health first aid trainings anymore. And I'm like, this is the time that people need to recognize mental illness more than ever, right? So I think it's important for us to hold local politicians and those policymakers, because there are social workers in those roles. And we have to make sure that they are feeling supported by the collective bodies that we exist in through NASW or the National Social Work Association and those things, so that we have like our voice in numbers rather than one person trying to make decisions on their own and trying to do it and being pushed back by other disciplines.
Absolutely. And I think that, part of what you're saying, just to kind of wrap it up, is really, really based in visibility and stigma, right? So when we see diverse faces and diverse experiences and leaders showing us that it's okay to talk about mental health. It's good to get a COVID vaccine. We could fill in the blanks here. That really has a powerful impact. I don't like to nod to celebrity much, but it's really powerful when people that have large following and media presence will take on some of these topics, because it gets to exactly what you're saying, Dr. Paul, that it becomes part of the public conversation, which inherently changes the public's practice. And so I think that back to what you were saying, kind of just being the critical voice that keeps raising it both so that's part of the conversation, but also so that people around us know that we support them. I really appreciate that perspective. Thank you. All right. I'm going to ask one more question and then we'll go. I see there's some questions in the chat. One I wanted to address is just, I did put a link into the chat about there was a question about what populations does Medi-Cal reach? And so I put in the link to Medi-Cal, which is the California word by the way, for Medicaid. So Medicaid is the federal program. Medi-Cal is what we call it. You know, California, we like to center ourselves. So we changed the name, which is different than Medicare, which is for people over the age of 65. So just to have that distinction. So I will keep looking at questions in the chat. I see one of the questions, Dean Gehlert, is to you about going deeper into why you don't like to see people say that they're going to educate others.
Got it. I'm glad you asked. Thank you. Because it's a little paternalistic. It assumes we have all the information, and if we impart it, things will be better. And so I do community-based participatory research where, especially in health, you know, trying to work with communities. And we're in an ivory tower. You know, we really aren't in the real world a lot. And so the things we test that look like they're going to work anywhere might not. So we partner with community organizations and community individuals. And when I say partner, I mean, we've got the best science, they've got the reality, they know the community, and together you can move ahead. And I've been educated as much by the people I work with as I educate them. So that's all I meant. It's just not assuming. It's being more humble, and most social workers are, but we tend to be an humbler profession, but just not to assume that we're going out to improve the world and that we have all the answers.
No, I appreciate that. And this is also a profession of lifelong learning and growth, right? So we always have to recognize that we have a lot of power in our position in terms of we have been given knowledge that I think is our charge to disseminate, right? Not to hold information so that people have to come to us, but rather to dispel and disseminate so that everybody has the same power and equalizes, but also to be listeners and learners. Because
so I can give you a quick example. So we were trying to sort of minimize the Black-white mortality in breast cancer in Chicago, and we were doing focus groups. So we went all over the south side of Chicago and did focus groups with 503 people. And we're trying to figure out how to measure stress, the best way to measure stress. So we sort of went to the university and the absolute, you know, what should be the best way of measuring it, right? And I thought, well, I'll ask people at the end of the focus group if they'll stay around a little bit and look at what we were going to use. And so I thought nobody would, but everybody did. And they're looking at these instruments and saying, that doesn't really work for where we are. So we were able to find other instruments, and it saved us like probably 6 months of work, because there's no universal. Things have to work with individual communities and individual needs.
I think since a lot of people in the audience, it looks like, are entering the MSW program, so they don't have that background in social work. Like, one of the first things we're kind of taught is that people are experts in their own story, right? So if they're experts in their own story, they're experts in their own community, and they're able to provide you information. You don't head into research thinking you have the answers, because research then means, why are you even doing it in the first place, right? If you already have it, why even conduct it? And I think that that's a big part of what we do, is ultimately provide and empower communities to share and tell their stories. Because while we do have our social work educations, we don't have everything on the ground, and those people are experts within that space.
I really appreciate that framing. Did you want to add to that, Tyan?
Oh, I absolutely agree. I've seen the same thing in the community-based work that I've done around healthy pregnancy promotion, that, you know, the perspective that we may have as researchers may not be exactly aligned with the perspective that the community has, even in the conceptualization of what the problem is. Right. So what is the problem and what are potential solutions, or what is it what are the needs, right? You can be very much educated by listening to the people who are affected and you know, sort of in the midst of some of these issues. They certainly are the experts on their experience and are in touch with what's happening in their lives and in the lives of those, you know, who are around them in their communities. So I would just echo what's already been said.
So I was trying to, I was working with a lot of other disciplines on this study, and they were taken aback because what I wanted to do was go out and ask people what they thought about breast cancer and what they thought contributed to breast cancer. And we learned so much. So the other disciplines, psychology, pathology, all of them, after a while were like, they started noticing things. Like they noticed when you drove south in Chicago that you didn't see any more billboards that talked about health. You know, they started noticing just changes, and it gave other disciplines sort of the social work perspective. Things aren't simple.
Absolutely.
Mhm.
So I had another question, and then one of our audience members has a question that falls into it. So I'm going to wrap them together. So my general question was, what are the areas of advocacy related to women's health that you see as a priority? But I do want to, there was an individual question from an audience member specifically around advocating for your thoughts on advocating for laws and policies related to caretaking for women and others, including paid leave. So I put the general question out with a specific audience question, if that's all right. And I don't know if one of you would like to start, or.
Okay, I'll start. I
Go
think
for it.
that one of the biggest pieces in advocacy is ultimately when you run down what are if I put in order, what is the major health issues for women, right? So I would start with like heart health, right? So heart disease and a lot of those diseases that are affected by that. Also, breast cancer is a significant one. And for me, mental health advocacy is very important. I am fangirling because until you read, until Dr. Cederbaum read Dean Gehlert's bio, I didn't realize I taught from your book when I taught social work of health at Rutgers. So it honestly changed, like that was maybe 5 or 6 years ago, and it changed my mind in the way that, or expanded on my thinking really, and how I looked at women from all generations, not just one, right? So we're always kind of talking about like maternal health and those sort of things with women, but women exist outside of the reproductive stage, right? And women also exist as trans women and all of those other intersections. So I think that those parts are very important. And I think one of the biggest, like one of my favorite chapters in her book is about about the elderly, right? That oftentimes how we leave them out of these conversations and only talk about the physical health aspects of it, but the mental health component is very important as we see suicide and depression rising within that particular subset. And I think those are very important pieces. I didn't hear the last question that the other person asked in regards to, what was that piece again?
So it was about kind of policies specifically related to caretaking and paid leave.
Absolutely. I think that like those are important pieces. I think a lot, Dr. Parker Dominguez touched on that earlier, was really in order to make sure that finances are kind of given and those sort of things are included within the conversation, because women caretake for moms and dads, they caretake for children, and oftentimes aren't able to take care of themselves, right? And I think that's a big part of the component, is to make sure that systemic changes and finances are trickled down, not trickled down, but handed really to women, right? So that they can ultimately not feel all of the stressors that come with being dragged in all these different directions, and ultimately take care of their health before their health becomes something that they're forced to take care of, right? And I think oftentimes we don't really practice preventative work in our society. And I think those things are very important, because oftentimes we take care of our health when it's an issue, right? And forced to do so.
Thank you so much. I'm going to go to Dr. Parker Dominguez. I'm mindful of time, and then have Dean Gehlerт kind of wrap it up for us, if that's all right with the panel. Thank you.
Okay. So I would just reiterate some of the things I had mentioned in my first response when we first started. The concerns again around being able to meet the basic needs of individuals in order to support their health and well-being. So advocating around some of these proposals around a basic guaranteed income or increases in the minimum wage, for example. I think paid family leave is something that is absolutely essential as well that we can get behind. And I also think that in this time of COVID, and all of the sort of economic fallout that we've seen from this in terms of unemployment rates, for example, in terms of who has lost jobs and who has not lost jobs, that also helps us to think about what are some of the sort of issues within our economy that relate to the huge sort of income and wealth disparities that we see that are only sort of getting worse. We saw the billionaires increase in wealth, hugely during COVID, and we saw people who live on the margins getting even worse in terms of their health and well-being and economics. So I think really looking at these are existing disparities. These are things that we were dealing with before COVID that just became exacerbated during COVID and really started coming to light. And I think we really we'll have opportunities, especially I think within the new administration, to be looking at some of these issues around social equity or social inequity that have been really highlighted during COVID, that we as social workers certainly can be powerful voices for marginalized communities, around impoverished communities, and be strong advocates, not only ourselves, but also in really garnering the voices of communities themselves, right? And really helping them see the power that they have within the democratic process, which we also saw demonstrated in our last election season. That is something as well I hope that we'll see more of in the future, now that folks have been able to see the power of the ballot and getting the vote out, and how things can be impacted.
I'm going to say the power of Black women, more centered. I'm going to center that statement. I appreciate that. All right, Dean Gehlert.
I'll try to wrap up a little bit. This has been very good, and I wish we could keep talking. So I think advocacy, don't just talk and complain. Find out who your politicians are, and it should be at the local level, the state level, and the national level, and team with others, because the way to make political change, I found, is numbers. It's numbers that do it. I think that helping women with self-care, the importance of self-care. It's okay to take care of yourself, and ways of doing it that don't impact what you need to do, but sort of giving people the license to take care of yourself, helping find safe places for women, and also working with other disciplines. I think the way to make change is to work with other disciplines. And I was thinking when I said that, it's okay to say you're going to educate them. That's fine. Other disciplines often need educating about the social determinants of health. And one thing that we haven't talked about is advocating for safety net in public hospitals. When we look at disparities in deaths, we find that oftentimes, as an example, we just published something in a surgery journal about hysterectomies. I just found this, one out of every 3 women is going to have a hysterectomy in her lifetime. We don't talk about it. And there are more modern ways of doing it that aren't invasive. The abdominal ones that you used to have, lots of infections, long hospital stays. But what we found was that some hospitals just they were just trying to make ends meet, and they couldn't teach the new methods. So advocating there too, that's something you can overlook, but I think we need to do it. So I love social work, I love health social work, and I hope you all enter our program, because together we can make change. We really can.
I appreciate that, and I agree wholeheartedly. Just wrapping up, I want to thank each of our panelists, Dr. Parker Dominguez, Dr. Paul, Dean Gehlert, and the USC Suzanne Dworak-Peck School of Social Work, Office of Admissions, Academic Affairs, Alumni and Career Services, all who pulled this together and were the hosts of this event. So thank you all. And if you have any questions or concerns, please email apply.msw@usc.edu and we would be happy to get back to you. Thank you again to our esteemed panelists for your time and to the audience for taking the time to join us. And we look forward to seeing you soon.
And our moderator.
Yes, I was gonna say, Dr. Theon, you did an awesome job.
Julie.